Hello and welcome to webinar series. Myself Shanti, and today's topic for discussion is all about recent advancement in stroke care. As we all know, yesterday was World Stroke Awareness Day, and the theme was focus on being every minute it counts. So for this, I now welcome our expertise, Dr. Durgesh Satalkar ji, who is our senior consultant intensivist from Yashoda Hospital, Secondabad. I welcome you, Dr. Durgesh.
Good afternoon, and thank you for inviting me for this webinar.
Yeah, thank you. And we are honored and privileged to have this platform with you. And yes, and now I request all the speakers in the panel to introduce themselves. Yes. Nagamani, will you start from yourself? Yes. Over to
Ma'am,
you.
good afternoon, Sir Durgesh sir and
Good afternoon, ma'am.
Shanti Bhattacharya ma'am, all the speakers. And I'm Nagamani, MSS Nagamani. I'm the lecturer from Government College of Nursing, ma'am,
Yes.
Hyderabad.
Welcome, Nagamani. Yeah.
Yes, thank you.
Yeah, Srinivas?
Yes, ma'am. Good afternoon, everyone. This is Srinivas from nursing officer from Government Medical College, Ramagundam Medical College.
Yes, we welcome you, Srinivas, and if you can just keep your volume little high so that
Okay.
we can hear you
Yes.
little high. Yeah,
Yes.
and yes, let us also hear from our senior nurse manager Ramakrishna. Yes, over to you, Rama.
Good afternoon, one and all. Good afternoon, Durgesh sir. Good afternoon.
Good afternoon.
Myself, Ramakrishna, working as a senior nurse manager, Yashoda Hospitals, Secunderabad. Thank you.
So we'll keep this session very time bound, and please feel free to have your own doubts because we have expert Dr. Durgesh, and we can always have this natural flow of discussion. Yes, going forward, like we would like to understand from you, Dr. Durgesh, stroke is a different concept in different individuals' mind. Like now, what is stroke actually in simple word? Yes, over to you, Dr. Durgesh.
So, stroke, if you see in a simple word, is there is something abnormal regarding to the brain. Okay.
Yes.
So when we classify stroke, it is usually three type of stroke which we commonly encounter. One is called as ischemic stroke. Ischemic stroke, what happens is the supply, arterial supply to the brain, there is some blockade. So that
Yes.
particular part of the brain is not perfused. That patient will have a ischemic stroke. More than 85% of the stroke are ischemic stroke.
Ischemic.
Remaining 10 to 15% are, again, there are two types. Hemorrhagic stroke, when there is a vessel ruptures and there is a blood in the brain parenchyma, that is called as hemorrhagic stroke. And another stroke we call as subarachnoid hemorrhage is a relatively lesser entity, but where what happens is the aneurysm, when there is aneurysmal rupture, then there again the brain surface there is a bleeding. It might be in the parenchyma, but it is a brain surface. That is third one called as subarachnoid hemorrhage.
Subarachnoid, yes.
So nowadays, yesterday we celebrated World Stroke Day. So stroke means every minute count. Means that if you delay in identifying or delay in the treating, so the proportionately the morbidity and mortality will increase. So now you know that the stroke is the second leading cause of mortality and morbidity all over the world. Only it is by first is the coronary artery disease. So now everyone talking about lifestyle modification early. So this is equally important in stroke also.
Yes, yes. So yes, very great insight on in a simplified way you have explained us regarding what is the stroke, and also we would like to understand whenever we browse and whenever we see a condition called TIA, also like transient ischemic attack. Like, is this also the under the category of stroke, Dr. Durgesh?
Yeah, actually what happens is a stroke, TI is a transient ischemic attack.
Yes.
What happens is there is a transient blockade of blood vessel. So the patient might be having some symptoms. Maybe patient might be a transient giddiness or slurring of the speech or any transient neurological abnormality. Followed by within 1 hour, probably patient recovers. That is called as transient ischemic attack. Previously, we used to wait for till 24 hours. But we are not waiting. We are probably within an hour, the patient revert back to the normal. But in the rare circumstances, the symptomatology may take up to 24 hours. But if you do scan, you don't find much of thing. Or there is scan is absolutely normal. So what happens is this, it is a warning sign. It is called as warning stroke.
Yes,
This
yes,
patient has a probability that within next 48 hours he might have a bigger stroke. So
yes,
if
yes,
he takes a medical consultation or if he sees a doctor within this during period, the further devastating stroke can be prevented. So TI is much more important. So if you consult early, we'll start the therapy so that further major stroke can be prevented.
yes. So yes, I would like to, have the consent from our beloved speakers who are present. Yeah, over to you, Srinivas. So you would like to ask your, doubts about, because this is a very vast subject. And in the morning when we were discussing, you said what are the early warning, signs of strokes, etc. And how would we just understand this, the acronym called FAST? Yes, over to you, Srinivas.
Yes, ma'am. Thank you. Sir, actually, before this, while understanding stroke, I want to know difference between syncope and how to identify early. First, that is stroke. As at village side, at field side, I want to know this. Some clarification I need, sir.
So
Yes. So I think there is a audible, you'll have to increase your volume, but I got
Okay,
your
okay,
point, Srinivas. You keep working on increasing your volume. By then, I will ask Dr. Durgesh whatever you have asked. Please increase your volume. Yes.
okay,
So
ma'am.
Srinivas wish to understand, Dr. Durgesh, that how do we clarify or how do we identify that key person is just getting these stroke symptoms or, progressing towards this condition. Yes.
Yes.
So, in order to understand, or especially at community level, so there is a lot of acronym or they are given in
Yes.
the community. So there is a called as FAST acronym. So any person who is having facial droop or the patient is a person who's having weakness of the any particular extremity, arm or suddenly he's having a speech difficulty. Many times what happens is we know that when the patient is talking suddenly there will be slurring of the speech or a
Yes.
patient is performing or any even might be knowing that any what the typical history is that I was or particular patient is doing the work suddenly he feel numbness of the hand or so you see the attender or the bypasser say that the facial symmetry has lost, so that is the probably where you have to suspect the patient might be having stroke. So the person to whom it has happened they may not be suspecting, but the bystander or the attendant we have to go more vigilant, especially in elderly patient persons group. So suddenly there are many history that they are having food but suddenly they are not able to lift the spoon. So these
Yes.
patients have a high propensity that they might have stroke. They should rush the hospital and start the investigation. Syncope is a terminology where it is not related to maybe patient that point of time patient might have stroke. The patient might have other pathology also. The patient might be having any cardiac problem, any arrhythmias. The patient might fall down or may have syncope also. So as such, we cannot differentiate from symptomatology. If anything, rush to the hospital, get a brain scan done, then only we are able to rule out or rule in whether the patient is having stroke. Early identification is most important.
Yes. So, Srinivas,
Thank
I
you.
think you're clear about the clarification which is provided by Dr. Durgesh. Any other concern related to this slide you would like to ask? Over to you.
Yes, ma'am. Thank you, sir. This I understood, sir. So only is there only early treatment is only we need to carry the patient from village at field level to higher center. That is the only treatment. Is there any first aid management at home, sir?
First aid management, look, the as per if you see, there are guidelines. So it is not necessary to always carry to the tertiary center. So what you can do is first, whether this patient has a symptoms, okay, and there is a high suspicion that patient might be having weakness or something. So wherever a nearest center is there, where there is CT scan facility is available. Okay,
Okay,
so you go to the patient, have a CT brain done. Okay, many times what happens is like there are different modalities of investigations are there. So all these
yes,
guidelines has put up keeping a non-contrast CT in the center. So always look, the MRI may not be available at the village level or even in the district or even the small places. So MRI
yes,
may be available in maybe tertiary or sometimes tier 2 cities. But what is the thing? You just do have a CT brain done. So probably still the symptoms are persisting. The CT brain is normal. So normal in early stages, or maybe it will take some time to appear on the CT scan. If there is no hemorrhage, but the patient definitely is having some measurable neurological deficit. This patient is, if more than 18 years, this patient is liable for receiving thrombolytic agents.
Yes.
Okay, are you getting it? So
Yes.
later on, if you have facility, directly shift to the hospital. Okay, within, like, there is again window period. If you receive within 4.5 hours, then the patient is having ischemic stroke, then this patient is candidate for thrombolysis.
Yes.
Okay, if you go beyond delay, then MRI will come into picture. Then you need MRI to further clarify what is happening, whether the ischemic stroke is in the window period or out of window period.
Yes. And few functionality cannot be reversed in case
Yeah.
initial stabilization is not taken place. Yes.
So yeah, you have to
Yeah.
have look this airway breathing circulation, and again you have to make. So
Yeah.
look, many times what happens is patient may be unconscious, he may be aspirating or something. So during that time you have to secure the airway, you have to stabilize the breathing, and then you can further transfer to the hospital.
Yes. And yes, we are also, wanting to understand the risk factor for stroke, like medical and lifestyle related factors are always there before a patient contracts this stroke. Yes, and yes, like this alcohol, substance abuse, and obesity, sedentary lifestyle, patient having many comorbidities. I think these are the likely factors where patient or client gets the stroke or anticipating that they will have a stroke. Yes.
Yeah, so many times you see undiagnosed hypertension. Okay, so especially these are the look. Patient might be having cardioembolic stroke also. They might be having arrhythmias also. They might be having atrial fibrillation also. These patients have high chances of ischemic stroke, or the patient having valvular abnormalities. Patient having history of any valve replacement, along with the patient is having some atrial fibrillation. They have high propensity to cause the cardioembolic stroke. In recently, what we noticed is young patient. Young means less than 45 years of the patient. They presented with sudden stroke. So when we retrospectively evaluate, at some point of time they had diagnosed with hypertension, but they are discontinued the treatment. So that is very utmost important. When we evaluate further, you see, if you do echo, there is evidence of left ventricular hypertrophy. That means that patient is having hypertension, but it's ignored. ECG changes are also pertinent to the hypertension. So
Yes.
ignoring these facts or any chronicity is very utmost important. If it is there, it has to be treated.
Yes. And discontinuation of and omission of treatment in, yes, as like I said, yes, Ramakrishna, have you seen anybody who, you're the stroke supervisor, like, yes, in the unit. So any other, risk factors you get to see that they are the potential client for the, for the stroke? Like as Dr. Durgesh said, undiagnosed hypertension
Yes,
and discontinuation of medication. And so I think, yes, everybody should just read the initial, clinical note so that they understand what are the real risk factors. Yes. Yes.
ma'am. We've
Yes.
seen so many patients because of they will not continue their treatment without any
Yes.
doctor suggestions or any clinician suggestion. They will not take directly. They will discontinue tablets. So
Yes.
many antihypertension they will miss. Suddenly we seen the patients. They will come with stroke like massive bleed or anything. So many cases we are seeing, and
Yes.
they
Yes.
lost their limbs or epilepsy or paralysis. They are seeing so many cases
Yes.
because
Yes.
everyone we should educate the some patients they doesn't know due to
Yes.
uneducated they will not meet any doctor. They will take medications again after 5 10 days 20 days. Yeah, I'm becoming normal, no need to take any medications. They will take own decisions.
Yes.
We have
Yes.
to
Yeah.
educate
That's
them,
yeah.
especially for patient attenders. We have to educate regular
Yes.
visitings and regular
Yes.
tablets how to take.
So let us also understand from Nagamani. Nagamani, are you there?
Yes, ma'am.
Yes, please, over to you for your own, concerns to be asked to the expert. Yes.
Good afternoon, sir, once again.
Good afternoon.
And why, sir, women are more prone to get more strokes, sir, than the men? What might be the reason, sir?
Probably that is maybe not, but hormonal. As probably what happens is look, all these are especially coronary artery disease or hypertension. They may be not very aptly or promptly diagnosed in especially in female patient. And the other thing is that whatever they suffer, like even the symptomatology, and the patient might be female patient, especially having hypertension. As we know, we tend to ignore further. So
Yes.
whatever unless big happens, we then never give a like input, especially in female cases. They themselves also underrated the symptomatology. Suppose the patient is having headache, so no, that is a routine headache. Why should I should consult a doctor? That is
Yes.
the main this stigma or something behind this. I current like one example I told, one of the female patient who was in their 60s. So she came to very total unconscious state, got intubated, we did scan, that is a big SH, subarachnoid hemorrhage.
Yes.
So we retrospectively evaluated, we called the family members, they give a history that 15 days back she had complaining of headache. So then I asked, why didn't you consult to a doctor? So no, only the female only tell, no, it will be fine, I'll take a tablet. So she took a tablet, she slept well, and the headache slightly better. But then why didn't you consult doctor? No, she said no need of consultation. Now that ignorance lead to this much of catastrophe.
Yes.
So
Yes.
we have to be more pro, and we have to be like investigate further. We cannot sit on the symptoms.
Yes, yes. As rightly said, yes, women always have this kind, they always take this kind of, excuses and self-diagnose and self-comfortable unless until they have this symptoms. Yes, yes, as greatly said, yes. So, yes, you have also told us like what are the types of stroke is. Yeah, Srinivas or Ramakrishna, do you have any concerns to
Yes,
be
ma'am.
asked to as?
Yes,
Sir,
ma'am,
what
I
are the
have.
delay? Sir,
Yeah,
what are the
please.
delayed complications?
Delayed complication, stroke like has a lot of devastating complication. So stroke can be like patient can die if not properly addressed because of thing, in the sense that secondary complication. First thing, look, stroke has happened. Anything, there is a rule, there is a principle in the neurology. Primary insult has already happened. You have to prevent a secondary insult.
Yes,
Prevention of secondary insult means you have to, what are the other, like oxygenation, carbon dioxide, temperature, sugar, blood pressure, all these things we have to monitor closely. So we have to prevent the secondary injuries as well. So if you don't attend or you don't treat it at right time, again further the patient might be having long-term consequences. The patient might be pelagic. Okay, or the patient might be completely having tracheostomy or aspiration. Those patients who might be with the thrombolysis going to the home, they may land up in rehabilitation for longer term care. So this morbidity will also increase, and the burden on the family will also increase.
yes,
So we have to be forefront. We have to identify early complication and we have to treat it.
yes, yes. Yes, Srinivas.
Sir, actually, at rural level, one myth is there, sir. Is corona vaccine can be cause for this stroke, sir?
There are, look, again, this is not proven with any studies.
Yes,
We don't have any studies that those who are taken corona vaccine does have, because look, corona, during corona itself there is increased chances of stroke and thrombosis. So whether it is because of corona itself or it is because of coronavirus, we cannot tell. So the
correct.
during literature, so whenever the corona happens, how you tell the that it is a thromboinflammation.
Yes,
Means in during virus itself, during active infection itself, the patient might be having thrombosis as well as inflammation. So we cannot differentiate whether it is because of act or previous corona. And I don't think there is any literature which is suggestive of coronavirus vaccine has increased the chance of
yes,
stroke. So I am not aware of. I am not sure that is will increase it chances.
Yes.
or
So
is this a kind of like myth which is
it is
already
propagating in the
misconception?
community that there is a myth that this has particularly taken a vaccine and stroke chances are increased. I said there is no any relation in between.
Yes, no correlation. Yes, Srinivas.
Sir, also again, I have a doubt. Varicose veins can be a cause for a stroke, sir. That may be cardiac stroke, that may be brain stroke.
No, there is again, look, uh, there are only four things. So we have to have, if there is a blockade, arterial blockade in case of stroke, maybe it is because of atherosclerotic disease process, or it could be because of thrombosis, or it could be because of mobile clot. Okay, so and maybe 20-30% cases, many times we don't know from where the thrombus has come. Basically, there is a stroke means there is arterial thrombosis, arterial vessel is artery has blocked. So many times we are able to find out from where the origin is, many times we are not able to find out. So even patient might be having arrhythmias, they may have embolic stroke. So we not can't find anywhere where is the thrombosis. So maybe it is from originated from cardiac. So we cannot exactly. But this varicose vein leading to stroke unlikely. I don't there is any relation and all.
Yes, yes.
Okay, thank you, sir.
So,
Okay.
yeah. And going forward, like, any kind of stroke, like, what are how long this stroke, last? Like, maybe patient may have, the ischemic or the hemorrhagic, of course, yes. Is it so that it lasts and patient is comfortable doing the activities of daily living, and then later he recognizes and visits to the hospital?
Yeah, so like stroke symptoms again it depend upon the patient to patient. So many times like even educated people also, so they are feeling numbness or weakness in their hands. Okay, so what they do, oh, this is because of lack of rest. Should I take a rest for 2 hours and then I'll probably feel better. So this is also happen after 2 hours the the extremity is totally not moving. So then the patient consulted to the doctor. This is quite common scenario.
Common, yes.
So whenever any stroke or anything happens, or I say that will be like if it is stroke has happened, definitely there is some weakness or deficit will be there in neurology.
Yes. Yeah. So we are just reaching to the main sub point, which is recent advancement in stroke care. So we would like to understand from your point of view, like we have jotted few, and what are the few recent advancement nowadays we are practicing in clinical scenario?
So usually previously till recently ischemic stroke we used to give thrombolytic agents. Initially
Yes.
we used to get alteplase. Alteplase has to be given over a period of 1 hour.
Yes.
Okay, so when we initiate, so but now the if you see stroke guidelines, so the stroke guidelines say that it is a time sensitive in the sense that if you suppose the patient has symptom onset at 9 o'clock, the patient reaches at 9:30 to your hospital. If you
Okay.
start thrombolizing immediately, so compared to the same patient who is reaching at 11:30, so the patient who reaches early will have a better prognosis.
Yes.
Okay, it is a time sensitive. You cannot delay. Oh, I have got 2-3 hours more. I'll wait till that time. No. If the patient is coming to you directly and if the patient is candidate for thrombolysis, you should start thrombolizing early. That is one thing. The next thing is that nowadays we are comparing because there is one agent called tinecteplase, which is more used in ACS, coronary syndrome. So nowadays the people are more inclined towards using tinecteplase. Why? Because it can be given as a bolus. So yes,
Yes.
so instead of giving over a period of 1 hour, now we can give just a bolus over a period of 5 seconds. The medication is in the body and it will start acting. Okay,
Yes.
so we need not to wait for 1 hour. Okay, that is what. Next thing what we do here is we in the MRI should only whenever code stroke is announced, we shift
Yes.
the patient in the MRI. We directly give there is thrombolytic agent. If the patient is candidate for thrombolysis, and ongoing MRI will be doing it. Then we'll be able to decide whether this patient is candidate for mechanical thrombectomy or not. So this is how the duration we can reduce. Already the medication there. And if you see there is a large vessel occlusion in the MRI angiography, so then patient will directly can be shifted from there to cath lab. From cath lab, we'll do mechanical thrombectomy. Again, this mechanical thrombectomy, previously we used to see that up to like in 2018-19, 16 hours is the cutoff. Now that
Yes.
cutoff has gone till 24 hours.
24 hours. Yeah.
Yeah, so mechanical thrombectomy we can do at 24 hours. Nowadays, again, people has gone further. There is thing that if there is a MRI, various images there, so flare mismatch is there, diffusion flare mismatch.
Yes.
Okay, so if the time we can, sometimes we can go beyond 24 hours also.
Yes. Yes.
Same
Yes.
is applied with the thrombolytic agents. If the MRI, probably there are studies are also there, wake up stroke. So we can increase the thrombolytic window till up to 9 hours also, but that has to yet to come in the practice. So they are saying flare and diffusion. If there is a mismatch, they can go for either thrombolysis or later on mechanical thrombectomy also.
Thrombectomy followed by.
Yeah.
And as we were discussing also, as you mentioned, the little recent advancement on MMA, like for subarachnoid hematoma for blocking the middle meningeal artery. Yes.
Uh, so yeah, so nowadays what we are some subdural hemorrhage. So what happens is the feeding vessel is middle meningeal artery. So now usually what happens is previously only decompression was used to do, but now we are blocking the middle meningeal artery and we are giving some time to observe the hematoma spontaneously. So nowadays blocking a middle meningeal artery is very commonly performed in SDH cases.
Yes.
It is in on the cards now. Like here also, we are doing it a lot of cases. MMA embolization.
So it is a like chronic period when we do it in a chronic period, or it is like subdural
No,
hematoma, acute phase
it
also.
is usually it is sometimes it is acute on chronic only. We used to do it.
We
So,
do.
but that depends upon symptomatology. If the patient is very
Yes.
drowsy, as he is requiring, they may go decompression also. If the patient is maintaining well, not much of midline shift or anything, then we can plan this.
Yes. So other way, yeah, speakers, over to you for your any concerns you want to ask, you wish to ask. Otherwise, we'll just go with this. What is the like? We keep looking at this biplane cath lab in treating stroke patients. So that, not even the care, this the role of technology also plays a very important in preventing and identifying the things. So what is actually this biplane cath lab in treating stroke patients, Dr. Durgesh?
Biplane cath lab is like it is a recent advantage. I think we are the first hospital in Twin State
Yes.
to have this. So biplane cath lab is gives a exactly 3D image of the our complete anatomy of the basically circle of Willis, or so we need not to again rotate multiple times. In single glow, it will give a complete 3D picture.
Yes.
So interventional radiologist has a very like from at the direction which they are going. It is gives a very crisp and a very magnified image. So it is quite easy for us to do radiology people to do
Imaging
mechanical
and
thrombectomy. So it is
yes.
quite advantageous.
Yes.
So to
So Nagamani, do you have any question to be asked? Or Ramakrishna?
Sir, what are the initial investigations for a stroke?
so initial investigations, I'll say if the patient comes to the hospital, so if he has in stroke, brief, if within 5 to 10 minutes you have history, if the patient is not having any significant history or maybe hypertension taking on the tablets, only investigation you need is NCCT, non-contraceptive brain. If there is no hemorrhage, only sugar is needed, and straight away you can go for thrombolysis.
Okay, sir.
Yes.
So if the patient is not having any other active medication, no blood thinners, nothing, so directly only CT brain and sugar, that is the only needed. This is how
So,
the convenient. Later on, you can have all battery of investigation. You can have CBC, chest X-ray, 2D echo, electrolytes, coagulation profile. Later on, you can add. If the patient is not history of taking any anticoagulation, there is no any contraindication for thrombolysis, you just rule out in the first 10 minutes, and you can, if no contraindication, directly start thrombolytic agents.
Right. Yes. Yes. So yes, I think we have just come to the end of the discussion, and yes, what could be the conclusion would like to give to the viewers who are all our nurses viewing this webinar? Yes.
As I already told you, the stroke is the second most common cause of mortality and morbidity in our like total all over the world. So
Yes.
anyway, the stroke is increasing in our country also. So maybe next couple of like years, it will be a pandemic. It will, you see lot
Yes.
of stroke cases. Stroke not
Yes.
only in elderly. The previous notion was, hey, stroke will happen in elderly patient. Now why stroke will happen to me?
Yes.
I'm
Nowadays
like
we
in the
see
younger age group, why should stroke
younger
happen to
generation.
me? So
Yes.
even 20, 25 years, we have seen cases of 25-year female also, she has a stroke. So it is not that stroke is no more a disease of elderly. It is can happen to any age group. Even in younger, in the 20s, 30s, they are also having stroke. So don't ignore the symptomatology. Consult doctor early. Okay.
And
If
I
you,
think physical form of exercises are very important because nowadays, people are bound to have this sedentary lifestyle. Everything, tomatoes, Swiggy, Zomato, tomato, everything is very available readily. So I think yes, physical inactiveness also is a very causing factor. And yes,
yeah, physical activity definitely helps to control a lot of things, not only
yes,
stroke related. So now I'll say prevention is always better than the treatment.
sure, yeah,
So we have
yes,
to prevent the occurrence of the stroke. If the patient is diagnosed with hypertension, he has to take a proper tablets to control it. If he has the diabetes, he has to control it properly as the doctor advises. So
yes,
prevention is always better than cure in the medicine.
yes.
That is the funda here.
Yes. So thank you for your valuable time. And yes, we wish request all the viewers to share this so much, so a lot of awareness can happen. And thank you for your time, Dr. Durgesh. And
Thank you. Thank you. It is
thanks.
nice interacting with you. Thank you.
Thank you. And
Thank you,
thanks
sir.
to all the beloved speakers as well. And please share this link so that our community and our viewers can have at least basic knowledge about stroke protocol. Yes. Thank you so much.
Thank you.
So much.
Thank you.